Nephrolithiasis, the formation of kidney stones, is a common urological condition that can impact any part of the urogenital tract. Management and understanding of this condition are critical for healthcare professionals, particularly in ensuring accurate diagnosis, effective treatment, and prevention strategies. Here's a concise breakdown tailored for medical professionals. Hashish diagnostic findings. CT scan, non-contrast spiral CT, gold standard for detecting stones, size, and location. Ultrasound, useful in pregnancy, can detect hydronephrosis. Urinalysis may show hematuria. Crystal analysis can indicate stone composition. Serum BUN and creatinine assess renal function. Treatment overview. Treatment options are determined based on stone size, location, and composition. 1. Symptomatic management. Hydration to facilitate stone passage. Pain management, often with NSAIDs or opioids for renal colic. 2. Medical expulsive therapy. MET, alpha blockers, e.g. tamsulosin, to relax ureteral smooth muscle and aid stone passage. 3. Surgical interventions, shockwave lithotripsy, SWL, non-invasive, for stones 2 centimeters in kidney and proximal ureter. Ureterorhinoscopy, URS, for stones in the ureter, especially distal, with the option of stone retrieval or laser fragmentation. Percutaneous nephrolithotomy, PCN, for large renal stones 2 centimeters, providing direct stone removal. Pharmacological management. The choice of drugs often depends on the stone's composition. Calcium stones, most common, managed with hydration and dietary modifications. Thiazide diuretics, e.g. hydrochlorothiazide, reduce calcium excretion. Uric acid stones, allopurinol reduces uric acid levels. Potassium citrate for urine alkalinization. Struvite stones, antibiotics for associated UTI, surgical removal often required due to size. Cysteine stones, chelating agents, e.g. tiopronin to reduce cysteine concentration, urine alkalinization with potassium citrate. Prevention. Hydration, 2.5 L per day to decrease stone formation risk. Dietary changes, depending on the stone type, generally low in salt, oxalates, and animal protein. Medications, based on stone composition, e.g. thiazide diuretics for calcium stones, allopurinol for uric acid stones. High yield points for specialists. Diagnosis. Spiral CT is the diagnostic gold standard. Urinalysis and serum tests assess for complications. Treatment. Tailored based on stone size, location, and type. MET for small stones, surgical options for larger or refractory stones. Prevention. Emphasize hydration and dietary modifications. Specific pharmacotherapy may be warranted based on recurrent stone analysis. This concise overview equips specialists with critical insights into the diagnosis, treatment, and prevention of nephrolithiasis, emphasizing evidence-based practices and current guidelines. Clinical case, nephrolithiasis. Patient information: age, 45 years, sex, male, medical history, hypertension, managed with lisinopril, no previous history of kidney stones, family history, father had recurrent kidney stones. Presenting complaint: sudden onset of severe colicky pain in the right flank radiating to the lower abdomen and groin, episodes of nausea and vomiting, noticed blood in urine once. Examination findings: vitals, BP 150 90 millimeter Hg, pulse 100 BPM, temp 37.2 degrees. Abdominal exam: marked tenderness in the right flank, no rebound or guarding. Urinalysis: hematuria, no signs of infection. Differential diagnosis: nephrolithiasis, pyelonephritis, appendicitis, renal colic, ureteral obstruction. Diagnostic workup: non-contrast spiral CT reveals a 6 millimeter calculus in the right ureter, just below the level of the pelvic brim. Serum creatinine, slightly elevated. Complete blood count, CBC, mild leukocytosis. Management plan: 1. Symptomatic treatment, IV hydration to promote diuresis. Analgesia: IV NSAIDs, e.g. ketorolac, for pain management, antiemetics for nausea. 2. Medical expulsive therapy, MET, tamsulosin 0.4 milligrams once daily to facilitate stone passage. 3. Follow-up and monitoring. Arrange follow-up imaging in 2 weeks to assess stone passage. Encourage high fluid intake, 2.5 Lils per day. Advise on straining urine to catch the stone for analysis. For preventive measures post-passage: dietary consultation for low sodium and low animal protein diet. Encourage regular physical activity. Monitor BP and adjust hypertension management as needed. 5. Surgical intervention. Consideration for ureterorhinoscopy, URS, if the stone does not pass or if patient develops complications such as intractable pain, infection, or acute kidney injury. Discussion points. The importance of stone analysis post-passage to guide preventive strategies. Long-term management of risk factors, especially hypertension in relation to nephrolithiasis, monitoring for signs of infection or acute kidney injury during the stone passage period. Follow-up. The patient should be advised to seek immediate care if experiencing fever, worsening pain, or inability to pass urine, as these may indicate complications requiring urgent intervention.